Thank you very much for the nice invitation again, dear Chairman, dear colleagues, ladies and gentlemen. I want to focus now on the octal scan in the diagnostic performing imaging of nuclear medicine. And before we are starting and looking how does it work, how we can perform a very high sensitivity and specificity of this method, we have to know what we have to stage. Of course, neuroendocrine tumors is a big group, as I told you before. They have a lot of definitions: endocrine carcinomas, neuroendocrine carcinomas, apodomas, or endocrine tumors. It is a big group, but we have the biggest knowledge on the group of gastroenteropancreatic tumors, the GEP-NET tumors. What we are knowing about this tumor specialties? Of course, the GEP-NET tumors is a group of 70% of the neuroendocrine neoplasias. Of course, it's a low incidence, only 2 patients per 100,000 per year. But we have to know, you have a big country, you have 90 million inhabitants. So this group is not small if you are calculating. The incidence might be up to 9,000 per year in your country. And of course, it's a small group only of 2% of gastric cancer. What does it include? The name GEP-NET tumors. Of course, the biggest part of those tumor patients are patients with carcinoids, nearly up to 60%, and then we can find all the other tumors, as I told you before, glucoconomas and lipomas. The prognosis is very important to know, is very good. But at first it depends on the histological type, of course, and the mitotic rate. You know the key value, meaning the mitotic rate, and if you have a key value lower than 2%, you have a very good prognosis. Also, if this tumor has produced metastasis of the liver or lymph node. Of course, it's better than patients with only a tumor and 1 tumor size, but if you look at the 5-year best survival rate, if after resection an appendical and rectal carcinoid, it's raising up to 70 and or 90%. So it's very high. And if you look at the group of GEP-NET tumors, the 5-year survival is up to 70%. This is very good. Also, if you include all the patients with liver metastasis, the 5-year survival is 50%. And this becomes better and better because of our knowledge. I can repeat it. We have to know to implement the right techniques of imaging and the right technique of discussion, the right therapeutical ways, then this group will have a big profit in survival rate. Before we are looking on the molecule of octreotide, we have to know how we can manage the nuclear imaging method. On the one side, we have our target, meaning in the case of octreotide scintigraphy, we have the somatostatin receptor on the one side on the cell surface of the tumor cells. And we must have also a carrier, a biological active molecule, which is going onto this receptor, meaning, for example, octreoscan, but this is the somatostatin receptor agonist. And of course, this molecule is linked with an isotope, and if you are choosing a gamma emitter, you have a wonderful imaging modality, and if you are choosing a beta emitter or an alpha emitter, this is a new discussion point, then you will have a therapeutic agent. So it is very important to understand that the scintigraphic imagination is works in the same way like therapeutic way of acting. So this slide, you know the targeting in the area of conventional scintigraphy using the receptor status or the metabolism. Of course, if you're using a PET-CT, you always can resume the receptor status and the metabolism if you have the tracers. And of course, on the other side, we have the therapy intention of our imaging method. So please remember that we can use this. So if we are looking on the affinity profiles of the neuroendocrine tumor cells, we have 5 receptors from number 1 up to number 5. And the important ones is receptor 2 and 5, which can be clearly defined by octreotide, indium octreotide, which we are using also in therapeutic measurements. How does it work? This is a cell surface, the picture of the cell surface with the somatostatin receptor. And if we are now present the somatostatin receptor agent, it is going and activate the receptor, and this complex of octreotide and receptor is going into the cell. It is internalized, and of course endosomal dephosphorylated. And this receptor can go back to the cell surface. Activation of pathways will be done by the activation of somatostatin receptor. But the important thing is that the radioactive complex is inside the cell and is betrapped. So looking over time, the concentration of radioactivity in the tumor cells is raising up. And this is the reason why we are using and performing the late pictures of octoscan. Not only 4 hours, not only 24 hours, but also 48 hours. This is the reason why we are performing this imaging in this way. So, clearly spoken, what for indications we have. We have we know that the neuroendocrine tumors is an indication for the octreotide imaging, of course, the GEP-NET tumors and so on. And of course we can also perform an image scan in the group of patients with medullary thyroid carcinoma, Merkel cell tumor, meningiomas, I told you about, and of course lymphoma cells also. Why? Because the cell surface is full of the somatostatin receptor, so you can think of a diagnostic step, but also of therapeutic steps by using gamma yttrium-90 DOTA-TOC or DOTA-TARTE as described from the Basler group, which have publicated this 2 or 3 years before. And this group, as I said it before, is growing. Growing because of our knowledge. I have to repeat it. Then, where we have the impact of this method? The patients with neuroendocrine tumors are not going at first to the nuclear physician. Of course not. We have the clinical doctors, general doctors, or doctors of internal departments, which are getting the information out of the anamnesis and the symptoms. And because of this typical signs, laboratory diagnostic steps will be performed. And if they show a typical sign of neuroendocrine tumor, a specific and systematic imaging has to be performed. And here I have to say that you have you must have the knowledge about these tumors, and of course the general doctor of course too, because he sent to you the patients. So he must know that you can perform an octreotide scan or an net imaging in the whole work of diagnostic step. And together with the octreotide scan and biopsy and other principles of diagnostic, the diagnosis is confirmed and then the therapy is discussed. How we are performing this imaging, no pre-medication I have talked about, we have standard dosage, we are giving sometimes laxative and full body scintigraphy for 24 and 48 hours inclusive SPECT and SPECT-CT. Of course, you know now why it is so important to get the later images, because the contrast is raising up over the time. Adverse effects are rare. Anaphylactic reactions were described. I have never seen them, and I did not meet a colleague who can report this, but you can read it in the literature. And as I talked to you before, up to 10 millisievert equivalent doses the patient gets. So let me show you some examples in the diagnostic of neuroendocrine tumors. This is a patient with circumcarcinoid, 4 hours, 24 hours, and 48 hours after injection. The circumcarcinoid was resected before. The question was to detect metastasis. And in these pictures I want to show you how important it is to perform SPECT. In this planar imaging, you might see no typical tracer accumulation, but if you are looking on this side below the liver, you can see that there might be a tracer accumulation that can be also in the colon, but if you're performing the SPECT scintigraphy, you can clearly define the tumor 24 hours and of course 48 hours after. So the metastasis of the intestinum is documented by this method, and you have to perform this SPECT, of course, to get a high sensitivity. This is a case of jejunal carcinoid. You have seen it before, the multiple metastasis and the metastasis of the liver also performed is also an SPECT tomoscintigraphy. But what I want to show you is the tracer uptake, the intense of the tracer uptake is raising up 24 hours after injection, as you can see it in comparison of both images. So therapy monitoring is also possible using octreotide scan. This is a case of a patient I showed you before with a lot of metastasis. They all were somatostatin positive, so radiopeptide therapy was discussed and performed, and this is the result before and this is the result after the therapy, and you can clearly define that the uptake is going down, the vitality of those tumors is going down also. So it is a wonderful monitoring instrument you have. We all can, or we can answer all the clinicians' questions. The question after diagnosis, staging and restaging. Of course, we can detect tumors of unknown primary. First of all, the liver metastasis in the case of neuroendocrine tumor is detected, but nobody knows where the primary. So you have the technique and the instrument for detecting this unknown primary. Of course, you can say something to prognosis. We have talked about tumors with a high grade uptake, so a well differentiation and a low uptake, meaning bad, poorly differentiation, and the poorer the differentiation is, the poorer the prognosis is. It's clear. Of course, we can select patients for radiopeptide therapy, as I shown you before, and as I talked to you before, radio-guided surgery might be a new theme in the future. If we are looking into the literature, we have very important information. We have a very high diagnostic accuracy in using octreotide, because we have a very high positive predicted value, and of course a very high negative predicted value. And this based on a very high specificity and sensitivity of this method. The effect of patient management is very high. 1/4 of the group of NET patients get a modification in staging and surgery and therapeutic regimen. This is very interesting and very important to know if you're using octreoscan. Of course, because of it, the high clinical valence is documented, and I have talked to you about the prognostic value you can resume out of these pictures. Where are now the perspectives and the future of this method? Of course, we have to look in this special method on the diagnostic intention. We can perform image fusion using SPECT and, of course, dual isotope techniques using bone scan and octreotide together in one investigation. And, of course, it can be that PET-CT using gallium DOTA-TOC and DOTA-NOC might be a modern diagnostic tool in the future, but the diagnostic discussion of the worth of this diagnostic is still going on and it's not clear yet. These are very fine tools for the nuclear physician. The SPECT-CT of the newest generation of an example of Siemens, Limbia T, and of course of Philips using a panel radiographic scanner. And the important thing is, because of the fusion technique of tomography and CT together, the resolution is coming down. Especially for indium imaging, the resolution is coming down to 5 millimeters. And if you are looking to PET-CT, where we have a resolution rate of 2 up to 3 millimeters, there is no bigger difference anymore if you use something like this conventional technique. So this is very important to know. The first publication on this field, SPECT-CT using octreotide in the diagnostic of neuroendocrine tumors, were published 2002 and 2003. These were the first pictures detecting neuroendocrine tumors with a very good localization because of the anatomical information of CT. I will show you some normal investigation results where we have discussed about. So this is a patient with a gastrinoma and an octreotide scan, whole body scan, and was performed. You clearly can define the tumor shows us a very high uptake, and if you are performing the SPECT, you can imagine that this might be a tumor in the region of pancreatic tissue, of course. But if you have also the image fusion technique and the CT information, the anatomical landmarking, then you can say, yes, of course it is a pancreatic tumor and it is in the head of the pancreatic. So these are very important information for the surgeon, how he can work, how he can act. But more impressive, I think, is this case. This is a case with mild metastasis of a carcinoid, and we have performed an octreotide scan, whole bodies, always the same procedure, and you can see one focal uptake in the right of the right lung. I think we can discuss in projection of the right hilus. And on the left side, in projection on the base of the left lung. So we perform the SPECT CT. The SPECT alone show us on the right side, no, this tracer uptake is not in the hilus area, but in the front of the right lung. But in fusion technique, we could see and detect that this is an skeleton metastasis of the sternum. So, and if you know that the patient has skeleton metastasis, the prognosis is going down. And because of this, you will act in therapeutic way very hard, and you use chemotherapy and so on. If you remember on the left side, the left focus, we have said it could be on the base of the left lung. The projection, the transverse slice of imaging show us a projection in the base of the left lung, of course. And if you perform fusion technique, you see, no, it's not the lung, it's the myocardium. So it was a metastasis of the myocardium. In 10% of the patients with neuroendocrine tumor, we can find myocardium metastasis. So it's very interesting to know. And you can see and can imagine that the SPECT CT produce a higher positive predictive value because of the clear anatomical localization. And of course, because of it, the therapeutic management is changed in a bigger group of those patients. So it's very important to think about this. But what we can do when we have no SPECT CT, should we use other anatomical methods to identify all these metastases in the body of patients with neuroendocrine tumor? And there was one publication of Exidin 2006 that up to 20% of the patients with GEP-NET tumor will have skeleton metastasis. And because of this, the indication to look after the skeleton is clearly documented for all the patients with neuroendocrine tumor. So there was the discussion, can we do in one investigation procedure 2 methods? Yes, we can. And this is one method developed in Hamburg from some colleagues. They inject the typical dosage of octreotide and at the same time of a bone tracer. And the gamma camera photo peak has to focus on the photo peak of indium and also of technetium. They are different. Because of this, you can perform an acquisition after up to 6 hours, 24 hours, and you have so 2 information of the bone and of the octreotide scan, and then you are performing image fusion to have the localizing information, the anatomical information of the skeleton in the picture of octreotide. How does it work? This is a case, a patient with lung carcinoid on the right side, and because of this, the octreotide was performed and also the bone scan. You can imagine that might be in projection of the right hilus, this tumor, but the information is not so clear. And if you are switching from the one to the other method, you can imagine that this tumor is in the right helix, you can switch to the bone information of the bone, and because of image fusion you have a better anatomical landmarking to describe all the pathological findings. And of course at the end you can look at the skeleton and discuss, is there a metastasis or not? In this case, no. Another example, 24 hours after injection of both tracers, is presented here. You can see the bone scan of a patient with a neuroendocrine tumor, and you can find some focal uptakes in the ribs. You have inhomogeneous uptake in the bone everywhere, and the information of octreotide is blended now into this picture, and you can clearly define that all these focal uptakes in the bone are also somatostatin receptor positive tumors. And of course you find more tumors now because we can have a look on the sternum. This is full of metastasis. Of course we can find now all the metastasis in the liver and the rest of the body, and you can find also the metastasis of the bone in the lower part of the body. If you're switching down, you can imagine the amount of metastasis. So let me resume for the dual isotope technique that is easy to implement. It requires minimal additional effort, and of course, this is very important, the quality of bone scan is not compromised by use of the medium energy or purpose collimator you have to use because of octreotide scan. And we can resume that with the skeletal anatomical landmarking, we have a more accurate localization of somatostatin receptor positive tumors, and of course we are detecting more bone metastasis in one examination. So this might be helpful. So the benefits of the octreotide scintigraphy is the characterization of neuroendocrine tumors. We have a whole body imaging. We can detect the extent of the disease, not only the tumor, but also the metastasis. We can provide intraoperative localization. We can select the patient for the right therapy, and we can imagine the follow-up with this method. So indium octreotide is a well-known and available radiopharmaceutical for imaging these neuroendocrine tumors or parts of the tumor, as we've seen in the talk before. And so let me conclude that nuclear medicine methods like octreotide scintigraphy feature, in addition to diagnostic, also therapeutic options, as I told you, which should be used intensively. Thank you very much for your attention.